without further ado, foie gras, soup du jour, or any of those other things, I have with me two wonderful people who are representing the Berkshire Medical Center's Nurses Union, and I'm going to have them introduce themselves. And this is one side of the story. Of course, you know that. These are the caregivers. If you've ever been in a hospital, and like I said, I grew up around nurses, so I just want to have you sit there, listen, don't judge, just think and process it yourself. So I will start with this lovely young lady. Let me get the camera in here. Got to show people how lovely you are. Oh, wow. Oh, there they are. Ha, there you are. Oh, good. You look good. We had a power surge this morning, and the power all went up, and it all went down, and now it's driving me nuts. But go ahead and introduce yourself.
My name is Ruth O'Hearn. I'm a registered nurse. Work for Berkshire Medical Center in the North Adams Satellite Emergency Room.
Oh, you're up there. Whoa, cool. I didn't know that about Ruth. And this handsome guy.
My name is Mark Brodeur. I work for Berkshire Medical Center. I currently work in post-anesthesia, the care unit.
Oh, wow.
Post-anesthesia care, where you wake up from surgery.
Hopefully. I'm only busting, man. No, well, and they're here today, and we're going to talk about the ongoing. Unless you've been, you don't read the Eagle or you don't pay much attention to the radio news, or they've been in negotiations with the Berkshire Medical Center for a variety of different things, and for quite a while. How long you been in negotiations?
Almost a year.
Yeah. So we're just going to talk about some of the things, and I copied this from the Eagle. I do my homework occasionally, especially when there's interesting things on the radio. It says, here's the headline: Berkshire Health System is at odds with nurses over staffing. So let's start there. What are the odds? What are your contentions for staffing?
I think
the unions.
For nurses, the biggest thing that we need is the correct number of people to take care of the patients.
Yeah.
We did ask for some small improvements in the beginning, and then for a long time we were just saying, can you just be accountable to what the administration says is safe? Can you just supply us with what you have determined is safe for the patients? And they have flat out refused to put any of that in our contract or be held accountable to that at all. So if
Berkshire Medical Center has staffing grids.
Yes.
They call them guidelines. The nurses who work on the units that have X many beds that are filled with X many patients say, we need the number of nurses. We would like it improved, but at this point, please staff with what you yourselves have said is a safe number to have. It includes nurses and support staff, including LPNs, CNAs, unit coordinators, all sorts of roles participate in care, but it's nurse-driven. And the hospital said, well, we know we have those guidelines, but you can't hold us to them. We can't guarantee staffing. Anything can happen. And they've offered to talk to us about why things happen, and once a year or twice a year to have a meeting with us and identify what happened. And in the moment, they said, we'll come and talk to you when you tell us there's a problem. Okay, we'll talk to you, but in the moment isn't the time. You have to have core staffing in place to provide safe care.
Sure.
They said they can't guarantee that.
Can you just pull it a little closer, because you're coming through, but it sounds like, pull it. You're not going to break it, honestly. But so what you're saying, if I understand, and let me just repeat back what I heard, they have a staffing scheme or plan or grid or whatever you call it. I mean, I came from a situation like that where we had minimum staffing that we had to have, even if we had the overtime people.
Correct.
And they have that.
They do.
Yeah.
Okay.
There are some units that have been newly created where those staffing grids were not created. North Adams Emergency Room is one. So we would like a staffing plan in place for each unit, and you never go below the core staffing. You staff up if you have more critical patients, the acuity is higher. There are reasons why you go up, but you should never go below.
It just Ruth or Mark, whoever wants to take. Here's an important point, I think, and just define acuity. You know, you're a nurse, you're in the ER. You have a massive wreck with bad burns and bad injuries. Just so the acuity level goes from, well, you got a sore throat to we're in crisis mode here.
Well, there's a national standard for acuity for triage. In the emergency room, it's a different world than it is once a patient has been admitted to the hospital. And there's national standards for triaging a patient, putting them into rooms or telling them that we have someone more acutely ill than you. We're talking life and death with people, both in the emergency room and when they've been admitted. The world of today's medicine, you don't get admitted to the hospital if you're able to take care of your medical needs at home. You're sick when you get admitted to the hospital. So when we, the nurses, talk about acuity, can you breathe for yourself? Can you get out of bed for yourself? Can you feed yourself? Basic tenets of life nurses are responsible for, and we can't be in two places at one time. We want our patients to live. We want them to have a good quality of life. We want them to have the meds that they need, the safe environment, and we also need the nurses to have a workload that is safe and appropriate.
Thank you. Thanks for that. Folks, if you're watching on TV, we had a power up and down here, and I'm still trying to, I want to get these good-looking people on because then their husbands and mothers call and say, there they are. All right. Mark, what are some of the sticking points that you guys are finding?
Our major issue is the staffing.
Okay.
And they don't want to meet us halfway or negotiate about it. They want it just taken off the table entirely.
And I have another thing here where you guys have filed something with the federal government. Union registered nurses at Berkshire Medical Center are accusing the hospital management of threatening to stop their health care and other benefits should they strike. Your complaint with the National Labor Relations Board.
Yep. So we actually have several with them against the administration. One is for them threatening to remove protected benefits by the federal government if we are to take any concerted union effort,
right?
Which could deter people from making a free choice to strike or do any sort of effort as a union to improve patient outcomes or our employment.
Yeah, and some of those are pretty well guaranteed by law.
Yeah.
So, just off the top of my head, probably wouldn't be a good thing to do. But there was another article about salaries and stuff, but that's not your guys' major gripe.
No.
The reason that BMC, our belief, the reason that BMC keeps focusing on salaries is a distraction from staffing. The rules that we are operating under with our negotiations are every single proposal that was going to be included in this negotiation process had to be on the table by the third session, which was long ago. You cannot introduce new proposals after the third session. Wages are part of our contract, so every single item we needed to discuss with BMC was on the table at the end of the third session. We have said to BMC, we want to talk to you about staffing.
Sure.
Yes, there are salary issues there. We are talking to you about that.
Sure.
Talk to us about staffing. Health insurance is the other one, and wages. They're all on the table, but let's figure out safe staffing, safe workloads.
It's amazing to me. Almost everything is amazing to me at my age, but it's amazing the correlation between staffing and salary, because that drives the bottom line. But I often wonder when we look at this, when you say staffing, and when I say you, I mean your union, not just you. Well, when you say staffing, it's everybody, right?
Yeah.
Break it down for the people out there and me, because by now you know what you're dealing with.
So I work in post-anesthesia care, so we always have a core staff.
Yeah.
So no matter what the day, we always have the same number of nurses and one nursing assistant. One of the floors, for example, if you have a certain number of patients, like 20 patients, you on the day shift, you should have a charge nurse. You should have 5 RNs. You should have and 2 nursing assistants and a secretary. So, and that's a little easier way. So you have the 20 patients, you have those 9 people to work with, but then they're short because they don't have someone to fill those spots. You get 4 nurses to cover the 20 patients. You don't have a charge nurse. You have 1 nursing assistant, and maybe you'll share a secretary with another floor. So then you have 5 people doing the work that 9 are supposed to be doing. And I mean, you're dealing with people's lives, and it's not like you only have one patient at a time. So you can see one patient, spend time with them. You're responsible for all of those patients.
What's the normal on the floor? What's the normal patient nurse ratio?
So the grids generally are on days 1 to 4.
Yeah.
1 nurse to 4 patients. On evenings, 1 nurse to 5 patients. And on nights, 1 nurse to 6 patients, but that's rarely the case these days.
Okay. Does that vary? And again, this is my, I have no idea. I go in the hospital to visit. Does that vary floor to floor, like, say, telemetry as opposed to, I don't know, medical?
No, they're essentially the same. Critical care step down has a lower ratio. So they should have 3 or 4 patients each, and the ICU has 1 or 2.
Oh, okay. Yeah. So, the whole crux of where this, I guess, gridlock is, bad term, I guess, gridlock, but is you want them, if I understand correctly, to put into the contract that they will live up to the minimum staffing all the time.
Yes.
We started out with saying we wanted these grids in the contract.
That's it. Yeah.
The hospital has expressed concern that they don't want everything to have the opportunity to go to outside arbitration. They don't want an outside party telling them, bottom line, this is what you have to do. So we made a concession and made an alteration to our proposal and said, okay, we'll have these grids, you'll comply with the grids, but it won't go to arbitration. It won't be in the contract that follows the steps of grievance process. They told us they don't want the grids. They don't want to be told, you're going to have this staffing in place. They'll talk to us about it at these meetings.
Sure.
And the bottom line will come down to the vice president of nursing, I believe is her title.
Yeah, I think
it will come down to this person who will take your feedback and either agree with it or not and make a determination. Well, those opportunities for staffing need to happen every day. There has to be safe staffing every day in every shift, not reviewed once or twice a year. And the hospital is telling us it's a big move for them because we will now have a voice at the table. Well, we have a voice at the table. We have a forum now for meetings with management, the labor management meetings. They're not fruitful meetings. They don't have an outcome where there is a determination that we've identified the problem, we've identified the solution for it, and we're going to move forward on this. And it's not working. The system that's in place is not working, and what they're offering us does not give us the voice that we need for safe staffing and safe workloads. It does not.
Also has 2 less nurses on their new proposal.
Yeah.
We have 5 on the current committee that discussed staffing patterns, and they're proposing 3 nurses, and then instead of monthly, just twice a year.
Folks, just to let you know, if you're just tuning in, my name is Bill Sturgeon, filling in for John Kroll. These 2 wonderful people, and they're from the union at the Berkshire Medical Center. And it's Mark Brodeur and Ruth and we're talking about We're talking about this headline: Berkshire Health Systems at odds with nurses overstaffing, and that's what we're talking about. And they represent the Berkshire Medical Center's Nurses Union, and it's. I think it's a public interest story, personally, because it's the only game in town. I mean, it's Berkshire Medical Center, or I don't know, wherever you go. But and so I think bringing them on is important to all of us to hear. And Ruth and Mark are really kind of laying it out for us, and I appreciate that. I have to go do this, though, because the government will appreciate this, the FCC. This is 89.7 WTBR, the Brave Taconic High School radio station in Pittsfield, Massachusetts. We're also simulcasting on Channel 16 PCTV. Thank you, Matthew Tucker, who is my direct access to PCTV and keeps me straight. And, well, it's like a full-time job. But the weather out there right now is it's still overcast. The winds are still variable at 7 miles per hour, 63 degrees. The time is 7:55. I also want to remind you tonight of this fundraiser for the Freeman House, and it's 7. It's going to be at Berkshire Community College at 7 o'clock tonight. It's called 7. It's a reading of a play about 7 women from around the world that have overcome unbelievable obstacles, and you just wouldn't believe it. So let's get back to I guess I'm at a loss if there's already a grid, right? Mm-hmm. Made up by them.
Yeah.
I'm stuck on the issue. Well, I'm stuck.
It'll hold them responsible to do what they have determined is safe.
But they made the grid.
So they would have to make sure that the staff was available. Right now, they don't have to make sure the staff is available. Or if they can't find someone to replace it, they just say, we don't have anyone, so there's nothing we can do.
Now, let's be realistic with that. What can they do? Because you have some specialized nurses, right? Mm-hmm. That hold other kinds of credentials.
Yeah.
If they can't find somebody with that's a pretty legitimate, not excuse, a pretty legitimate rationale. Listen, I don't have a nurse with this qualification.
Well, if that was the abnormal,
yeah,
but that's the normal. That's the day-to-day answer when a schedule is posted 30 days in advance.
Oh, wow.
14 days in advance, and you're telling me we have 50 holes in 100 slots. There's a problem. This is not a little problem.
Yeah.
So when BMC made a decision some time ago to take many full-time jobs and create many part-time jobs, a lot of the solution possibility is to offer our nurses who are now part-time, who took part-time jobs because that's all there is, it is the only game in town, offer them more hours and say, we're going to fill our slots by having full-time nurses committed to working here, and we have per diems who will fill in when you want time off or when we have a vacancy or an unscheduled absence. There are options available. Create jobs. Fill those jobs. Don't leave vacancies posted.
What? And not to, and I know this is an unfair question. Why did they do that?
Well, they
Was
told
that a
us it's
cost
not about
saving?
money. They told us it's not due to money
because
we said there's many nurses saying, I want full-time hours. I want a job that comes with insurance that is affordable. And BMC answer at the table was, we did not make this decision based on money.
Well, it's kind of okay if that's what they say. I'm not a medical person. I've done tons of staffing in my life. Many hours, and it's so much easier when you have a staffing pattern, and like for a full-time 8-hour-a-day post, mine's were post, you're a post, you needed, with you figuring benefits and time off and all this, 3 shifts a day could be up to 6 people per post, depending on the benefit package. And so I mean, to me, and who am I? But to me, it's so much easier to staff with full-time people because, otherwise it's like you're going crazy calling all these part-time people to see who'll fill in the slot. That's just me, I'm sure there are people there are bright and smarter than I am, but I just wonder why they continue to do that. And again, I know some nurses who've left BMC and gone to work in doctor's offices simply because of what you just said. Full-time jobs, 40 hours a week.
I'd also like to point out to you that
Sure.
I find it both disheartening and distasteful, the disrespect of the letters that BMC, the ads that BMC puts in the paper that talks about the greed of nurses and the salary levels that nurses have achieved, because I work 36 hours a week, which BMC says is full-time. If you need me to work extra, it's going to be overtime because
Right.
that's our contract. So when I work overtime, it's a different pay scale. It's an overtime rate. I'm not doing it because I love doing overtime. You have an empty slot. You've asked me 10 times, will you work? Will you work, please? So we do it to provide care for our patients, to keep a safe work
Sure.
environment, and to help our peers who are going to work short again and again. So for BMC to say, look at these salaries that these nurses are making, hold on now, why am I working overtime?
Yeah. Yeah, this the old battle of that goes back long before BMC or this conversation. Where is it better to run overtime or is it better to hire a full-time person so you don't run overtime? And depends on your point of reference, I guess. But I can tell you from mandatory overtime that I worked in my career, after a while the money isn't worth it. You're so tired. When you're working, 7, 12-hour days, and you're just exhausted. You go home, what is your life? Yeah. You go home, hi, honey, how you doing? Hi, kids, I'm in bed. So that's just my, old cop point of view of it. But what does it take when you work the overtime? What does that take a toll on you?
Sure, it takes a toll on me, and that's the reason why our contract addresses mandatory overtime will not happen.
Oh.
If there is nurse fatigue, there are increased errors. There is increased risk of injury to the patient. There are studies that demonstrate nurses can't work safely past a certain number of hours in a day.
Sure.
It's a patient safety issue again.
And the nurse is doing all kinds of things. I mean, if they're reading blood pressures and they're giving medicines and they're distributing medicines, giving shots. And you don't want anybody really tired doing that.
Correct.
I don't think you do. But now, so I'm really stuck on this. I know, and you're probably saying, this guy is just slow as grease, man. I'm telling you. But it's just, you just want them to include they developed it, not you, not the union, staffing grids in the contract, and you won't go to arbitration or whatever if something happens. Did I understand that right?
Well, at this point, we're even past that. We're not even asking for that anymore.
Oh.
At this point, we're asking for an unassigned charge nurse and for things just not to get worse. They said they can't guarantee that it won't get worse. In fact, it most likely will get worse.
But why is that? Help me out. I'm stuck on stupid here.
They're concerned about the future, I guess, how things will play out in the future. But they've been telling us for 10 years how bad things look, but they consistently make huge amounts of margin or profit every year that they use for buying other facilities all over the state. They just purchased one that was listed as over $6 million, worth that much. I don't know how much they paid for it in Holyoke. Right. They have them all over the state, and they're for-profit long-term care facilities. And then they use it for bonuses and,
Yeah. I guess... how much of this goes back, and I hope that you consider this a fair question, how much of this goes back to their uncertainty because of the uncertainty in Washington about where is healthcare going? I'm in the VA system. And let me caveat that by saying it's so much improved, it's unbelievable, okay? Compared to what it was 48 years ago when I went into it. It was horrible. There's no other way to describe it. It was they all should be in jail. But this said now, there are those folks that are pushing for, what is it, single payer situation? That's almost like government health care, isn't it?
Yeah, it would be like everyone had Medicare.
Everyone had Medicare. So prices are fixed and all that. Do you think that's what they're afraid of? They're afraid to commit to? I mean, I'm not taking sides here. I'm just saying, do you think?
It's hard to say, but right now our community deserves care. So if in the future something changes, that'll need to be addressed, and it may be planned for the future. But that doesn't change the fact that the patients that are in our hospital right now deserve to be cared for. They deserve to receive excellent care, and you can't just base it on let's hope that we catch it. Let's hope we don't miss something. Let's hope that something horrible doesn't happen. If I say I can take care of 4 patients safely, your family member might be my 7th patient.
Wow.
So what's happening when he needs to go to the bathroom, or she's all of a sudden having chest pain, or she's not thinking clearly? Who is there to see that person?
Yeah.
If we don't have the hands and the people available to actually provide that care. So that's something that we run in daily, and most of the time we're just lucky. It's just pure luck that something horrible doesn't happen.
I see. But you guys must be doing something right, because they got all these banners all over the top, whatever, and this banner and that banner.
It's very hard, because the reason that BMC can earn those kudos from the nationals and the state levels, because of the care that's provided by the nurses and the staff.
Yeah.
And Mark works in a unit that allows for defined staffing, because PACU has national standards of when a patient comes out of anesthesia, they must be allocated X many staffing depending on their level of anesthesia.
Right.
So he works in a department where we're going to have those staff in place, because you can't put patients in surgery if you don't have that available staff for them after surgery.
Oh, I never knew that.
So he's lucky. The other departments, there are goals to have in place some safe staffing for everybody, but there aren't current things, except Massachusetts has a law for ICU staffing.
Okay.
So our ICU is staffed by that, with that in mind. However, the other departments don't have that safety net. And BMC tells us that they know they should have this many people. They've estimated what each patient load means to a nurse. But if you recognize it and fail to staff for it, it doesn't work for the patient's benefit. The nurses end up without the ability to recognize a change in condition, without the ability to give a medicine and then do a follow-up assessment to see, did that medication work? Did it create a fall risk? Have I done something that might potentially harm the patient? That's on our license. We need to make sure that we have the resources available to provide safe care every patient, every day, allow them to have good outcomes, the very best patient care environment. And we can't do it with what BMC is allocating for safe staffing.
Also, for decades, there's research that says for every extra patient you have, your chance of dying increases. So there is a real documented risk to our patients.
Wow.
That every time they make you take an extra patient, all of your patients have an increased chance of death.
Wow.
We're operating under evidence-based practice. This is where we are. This is what the outcome is. We're working toward achieving for the patient to go home and have the quality of life, or to go wherever they need to go for the next step after their acute illness. And there's evidence that says you need each of these things to happen. It's our job to provide those skills and those services. We went to school to learn the skills. We work to have our community be a safe place for these patients to come and get care. And we need the staffing to be in place to provide it.
To me, this whole discussion is there's so many things that laymen lay people like me don't know and don't fully comprehend. And we're going to get back to you guys. This is WTBR, the Brave Taconic High School radio station, 89.7 FM on your radio dial. We are simulcasting on channel 16. PCTV. Thank you, Matthew Tucker, for making that happen. The time right now is about 8:09. Still, the wind is variable at 6 miles per hour. The skies are still overcast, and it's 63. Or when the computer rebooted, it didn't reboot, but one of the two. So who knows? I'm here today with two representatives of the Berkshire Medical Center Nurses Union, and Mark Brodeur and Ruth Hearn. Mark works in the anesthesiology department, so if you're going to have any operations soon, you'll wake up and you'll see his charming face, hopefully. But and Ruth, she works up in North Adams in the ER.
Yes.
Yeah, you got to take your hat off that. You got to take your hat off to BMC for reopening that thing. I mean, I have friends in North Adams, and they love that old hospital, North Adams. And I had to go there a couple times to see a doctor, and I often thought, why did they build it on top of this hill? Good God! I mean, I went in the summer, but that to me, you say whatever you want. I think they did I applaud them for doing that, because that's a long way to go. You know far better than I. If you're having a heart attack from North Adams without any stabilization to BMC. From especially some of the towns that only use volunteer ambulances, what they call it, this golden minute or whatever, golden hour.
Golden hour.
Yeah.
I live in Reedsboro, so we're one of the feeder units to North Adams. And when the North Adams facility was closed, it was very concerning. I give kudos to BMC for stepping up and opening the facility. That would be a program for another day to tell you what I would like to see come back to North Adams in the form of a full-service hospital.
You're a good guess.
However, the emergency room, we do indeed provide care for heart attack STEMIs. We send them on to BMC or down to Bay State, depending on what their needs are. We provide the same level of care in our emergency room in North Adams that is provided in Pittsfield. The ambulance services have greatly had to enhance what their available services are. Their volume of patients has exponentially exploded because they can't bring them all to us. There's a decision-making process that happened with the Department of Health that the ambulance service has certain people they can bring to us, certain people they can't. But there are people that come to us because they're not stable enough to transport.
Sure.
So we stabilize them and ship them on for their tertiary care. But it is a busy emergency room. It is a needy environment. Our community has very old, very sick people. Their needs didn't change because the hospital left.
I get into this battle, and let me ditto that. Pittsfield is an aging community.
Yes.
And when I go to, I have a couple of relatives that are in and out of the hospital pretty frequently. They're elderly. And when I go, I see the age of the patients. There's not a lot of young people there, on the floors.
Yeah.
And I guess we go back to acuity again, and like I have, I know someone who has, Parkinson's and cancer and a bad heart. When they come in the hospital, I mean, they're like, you want to make sure they got the right care, and want to make. You both said something. I think I go back to, and I want to. It's not just when nurses are. I saw this with my own mother. They're always observing, patients. They give the medicine, and then they come back and they, how'd it work, or how you doing? Do you feel better? Does pain gone? Whatever the question. So if you don't have the correct number, you don't have that backup. Is that kind of right or wrong?
Sometimes it's just how they're breathing and how they're thinking, which are very early signs. And if you don't have the time to spend with your patient to know how they were before, you won't even see that change. And then it'll end up being too late, and then they need to be bumped up to the ICU or some other level of care because there wasn't the person available to be like, oh, I notice you're acting a little differently. Let's investigate that. Let's get you the care you need now before it turns into an emergency.
I read in the paper where the docs in the hospital have, and elsewhere, have asked you not to strike. Does they have a lot of weight?
Oh, I respect the doctors immensely. I will point out, however, that that's a very small group of doctors who signed that letter.
Yeah.
We know that we have the support of many of the licensed practitioners. It is, as you said, a work here or work nowhere. And some people are not as willing to be vocal or to have their names published on a letter or to write letters to the editor because there is you get feedback from that, and it might not be in a positive way. It takes
That was
courage.
Beautifully said, Ruth. Honest to God, you should work in Washington.
To be involved.
You should tweet for the head tweeter there.
I believe that we are all accountable for our own actions, and I'm willing to come with Mark and say, here's the problem. Here's where we need to be when we end our discussion.
Right.
We are not here for ourselves. We are here because we represent our fellow nurses.
Sure.
I work in an environment where every day I don't know what's coming in.
That's
and
right.
When you say you observe nurses are always doing an assessment, I work as a triage nurse in addition to working at bedside. You start triage from the minute you lay eyes on a person. It's a 1-minute triage. Are they at risk of dying? They're here right now. Do I need to bring them back right now? Their color tells me something. Their breathing tells me something. Mark sees the same thing after anesthesia. Are they okay? Are they coming out of this anesthesia okay? That's his job, and you can't do it if you're not looking at the patient. If I can't see them, I can't assess them if I'm over there. I can't.
There's a lot of reality in this program, ladies and gentlemen. My name is Bill Sturgeon. This is sitting in for John Kroll or whatever, doing something for John Kroll. I have with me this morning Mark Brodeur and Ruth Ahern. They are representing the nurses union from Berkshire Medical Center. As you've been reading in the paper and listening to on the radio, they're in tense negotiations with the Berkshire Medical Center administration, and it basically boils down to staffing and probably the word, would this be an appropriate word, guaranteed staffing?
Yeah, I mean, we're kind of past asking for that because you have to keep giving stuff up in order to negotiate in good faith.
Right.
But, and other contracts around the state have grids in their contracts. They have guaranteed charge.
So this isn't an anomaly.
So it's not uncommon or anything out of the box, and those hospitals are doing fine. And their patients are guaranteed safer care.
Yeah.
I think our community deserves that.
Well, if you read the letters to the editor, I mean, I don't. I'll be very honest. I don't read them every day, but I will say this: that the majority of the ones I have read have been very much in support.
We appreciate the community so much for standing with us.
Yeah.
You can see the lawn signs all over Berkshire County.
I know. I couldn't believe that. I thought you guys were running for office.
We can't print them fast enough for the community. So there's well over 1,600 right now.
I think this, as I said, this show is a public service show, and it's an informational show. If BMC wants to do a rebuttal, please get a hold of me, and we'll make that happen. But with all the lawn signs, with all the letters to the editor, with some personal knowledge, because I've been there over the past winter quite a bit with relatives, it's hard to see we, the lay person, we don't see the adjustment in care. Do you know what I'm saying? I mean, all I can say is my relatives who've been in there have received excellent care, great nurses, but we don't see the stress and strain on those nurses. Am I making any sense?
Typically, we do everything we can to make sure the patients feel as safe as possible.
Yes. That's what
we don't go to the bathroom. We don't eat food on a 12-hour shift.
Wow.
We stay late to document, so that way we can spend our entire shift actually providing care and then document everything after our day is over. So we've pretty much exhausted all of the little tricks we can use to make sure the patients are still getting the care. But it comes to a point like doing massive amounts of overtime or staying late. Like, you can only do that for so much, for so long before everyone gets broken.
Right. I can attest to that. Believe me when I tell you. So the next step is what?
Well, we'll continue to reach out to the community. We really appreciate all their support. We're reaching out to the board of trustees. We want to make sure that they're aware of what's happening. Sometimes if you only get one side, you might not have a full picture. We do not want to negotiate with the board. We just want to make sure they're aware of our concerns and that they have a clear picture of both sides of the situation. Our administration is not moving. They've been holding pretty steady for quite some time now, and they don't even want to discuss workload, which is a mandatory subject to discuss. And I think that, like, today we'll go see one of the board members at Greylock Federal Credit Union. To just say, please listen to us. Please hear our side and know what it is we're looking for. Our patients deserve that.
And to further answer your question, when you said what's next, the nursing union, we have a vote in place to authorize our board, our negotiating board, of which Mark and I are members, to call a one-day strike, to tell the hospital, here's a date. It is not our goal to have a strike. We, the nurses, do not want to have a strike. What we're saying to the hospital is we are a united group of professionals who provide a great service to our patients. We want the respect of honest negotiations with you. Talk to us. Let's figure out the staffing and listen. We can't do it the way you have in place now. It's not working. It's not safe. We don't want to strike. The hospital is the one that have put out the word strike, strike, strike in their publications, not us.
And again, I think going back to the community and the community support, and I understand I really do understand where you're at. But I don't think anybody wins if that happens. That's just my, short, fat, bald opinion. But you got to do what you got to do.
But that's also why we keep showing up to negotiations, even though there's blatant disrespect every single negotiation.
Who is their negotiator?
Diane Patrick.
Sounds not. Is that the former governor's wife?
Yes.
Oh, cool.
She's a lawyer based out of Boston, I believe.
We love people out of Boston.
Yeah.
And now local politicians. I've seen where my friend, and I mean that from the bottom of my heart, Paul Mark, has kind of stood in by your side.
Yeah, he's been wonderful. Really supportive.
I've had him on the show several times. I mean, I don't care for his beard, but what are you going to do? But no, how about the others? Any TFB, Trish Riley Bouvier, has she been instrumental? The mayors? You got a great mayor up, and I'm sorry he's leaving. I love Dick Hockenbright.
Yes, we had a great support in Gail Caridi also. We missed her immensely.
God, love her.
Yes,
what a tragedy in life.
And that election will maybe give us that support base back again.
Oh, good.
We have invited all of the legislators. Some of them have come to our negotiations and spoken with us, and we've shared with them what our goal is for safe patient care, safe workloads.
How about Adam Hines? I'm sorry, I didn't mean to step on you, Mark. Go ahead.
I was also going to say Helen Moon, who's running for Ward 1. She's been incredibly supportive. She's come to our pickets and written letters to the editor and just really been a voice outside of BMC to help. She's also a nurse.
Oh, I know. I don't endorse people, but I have known Helen Moon work her way. She should be one of these 7 women they're talking about. I'm just going to say that. Yeah. She talk about pulling yourself up by your bootstraps. It's an old Army thing. I'm an old Army guy. Hopefully this will. I guess when I say local support from politicians, how about Adam Hines? Has he gotten involved with you guys at all?
I think that we may have met with him once or twice.
Okay.
I'm not sure exactly what his stance is.
Okay. He's a good man, and I think what I find about Adam, and maybe it's his UN exposure in negotiations in the Middle East, he listens. It's the first thing. He listens, he absorbs, he does an analysis of the facts, and he accomplishes things. And like Ben Downing. Ben Downing was the same way, God and Adams. But I hope you get some more support locally from politicians. What I really hope for is that this thing, and I like to, at my age, I like to live in a dream world because you can't remember the real world. But when you said memory, one of the first things to go. You're right there, brother. I got your names written down on 15 pieces of paper, so I won't forget them. But we have to get through this. This is very important to our city, to our county, to southern Vermont.
Yes.
Eastern New York. We BMC is, to a lot of sick people, that's their last chance.
Yeah.
Yes.
They don't have another option.
They don't have another option. And if they go Bay State or St. Peter's or afterwards, that's fine. But they got to get out of BMC and stable enough to go there. And I just had Pete White's mom, and he's a city councilor here. She had a heart attack, went to BMC, got stabilized, and shipped down to Bay State. Stabilized at BMC.
Mm-hmm.
You stabilize it to at least get them to BMC in North Adams, which I think is a beautiful thing because, like you say, a lot of Pittsfield and North Adams and Adams, they're not recruiting a lot of teeny boppers. You know what I mean? More canes than and walkers than dance shoes. I wish you guys the best.
Thank you.
I wish both sides. Negotiations are always tough, but I wonder sometimes do they have to be? And that's just my opinion from nowhere. I mean, I've sat on negotiations. I've been involved with negotiations. I've seen them go very easily, and I've seen them get really rocky. And you guys are in some rocky road right now.
Yeah.
So, whatever you decide, best of luck.
Thank you.
Thank you so much.
No, and when you go when you go back, you can tell all the people you see that I can't thank them enough for what they do every day, and they go unsung. Like I said, I've had a lot of experience there last winter and this summer, but don't give up hope. You're in a beautiful career field, and you do so well. And again, folks, if you have more questions, can I contact your union somehow?
I don't know.
I didn't want to catch you flat-footed like that. I'm sorry. I shouldn't have done it. No, but here's the thing. I'm going to give them my card.
Okay.
And if you have questions, you can get a hold of me, and I will relay it to them, and they can answer it if they want. But here's the thing. Read everything. Just don't read one side. You have to read everything and assess it yourself. Go think about your own experiences, be it the emergency room, be it whatever, hospital, birth, whatever, and think about that. I, again, wish you all the best of luck.
Thank you.
And when it's over, will you come back?
Yeah.
Cool. Yeah, because I think it's what you bring to, a lot of us don't know what your career field is. It's very demanding, and I think what you two really demonstrated here this morning is your care for the patient. Patience.
That's why we became nurses.
Yeah. But and you illustrated it so beautifully, from watching them breathe to checking to see, these are things the lay person, me, we don't see, but when you're walking, you're always observing. And good luck to you both. Good luck to the union, good luck to all the nurses, and good luck to the administration. Should be a middle ground somewhere.